Hello, it's Dr. James Hall, and we're doing another video. Today, we're going to be talking about metformin, CKD, and acute kidney injury. This is a case that I just saw just now. So this is hot off the press. I just got this case out the oven, and I prepared it for you. We're going to serve it to you. I am a nephrologist. I've been practicing for about 20 years, and I'm trying to help primary providers, NPs, and PAs bridge the gap from medical knowledge to clinical management. There's a big difference in what you know in the classroom, passing tests, and actually taking that information and extrapolating it over to the clinical side when you get a patient coming in your clinic. So today we're going to talk about this 82-year-old lady who came into my clinic. She has a history of hypertension, diabetes, GERD. Her primary doctor checked some labs on her, and her GFR was 14 milliliters per minute with a serum creatinine of 3.24. Now, he sent her to me because of this acute drop in renal function, and basically no one knows why her renal function is low. I don't have any blood work, any old blood work, so I don't have any recent labs to compare this lab to. The patient said that she was somewhat been having some diarrhea. She felt like she was dehydrated when she had the labs done that day, and she felt like, she wasn't drinking enough water. So, incidentally, other important lab findings, her serum bicarbonate level was 13. That's a ding, ding, ding moment. A light should go off to tell you, okay, this patient not only has acute kidney injury, but she also has acute metabolic acidosis. When you see those two things together, you should think, something's significantly damaging her kidneys. Is it ethanol, ethylene glycol, antifreeze? Is it aspirin, salicylate poisoning? What's causing this? And if you see a significant acidosis, like in this case, you should automatically think what medications could be doing that. So I looked at her medications. Her medications included amlodipine, hydralazine, hydroxyzine, meclizine, metformin, salumedrol, and metoprolol. So out of those, which one you think could be causing the acidosis? Ding, ding, ding. Doo, 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 doo. Metformin is a very common cause of lactic acidosis. So this patient has a severe metabolic acidosis from metformin therapy in the setting of renal failure. Now, I don't know why she's in renal failure yet, but we checked a barrage of labs to try to figure out why. My suspicion is that she was dehydrated that day because she was having diarrhea. She was outside in the flowers all day, according to her daughter. But, metformin in of itself does not cause renal failure. Metformin causes lactic acidosis if you have a low GFR. Metformin is metabolized by the kidney and is usually excreted almost unchanged. So that particular drug, when it's metabolized, it causes a lot of acid to build up in your system, and your body cannot handle too much acid. And this patient has lactic acidosis from metformin. And she also has acute kidney injury of unknown origin. So how do we manage this lady? First thing we did was we got an ultrasound of her kidneys to try to see if she has an obstruction or blockage. We also repeated her renal function to see if she's improved. We checked the ANA to see if she has lupus nephritis. We checked hepatitis panel to see if she has hepatitis-induced glomerulonephritis. We also checked immunofixation electrophoresis just to make sure there's nothing in the background like a gammopathy or some type of monoclonal proteinemia that may be causing this. The other thing that's so important when you see an acute kidney injury is check a urinalysis as well as a urine protein to creatinine ratio. The urinalysis tells you if there's blood or not, protein or not, but the urine protein to creatinine ratio tells you how much protein your patient's spilling. That's important. That's critical for you to know how much protein your patient's spilling, especially in the setting of acute kidney injury. So there were no medications on her regimen that would specifically cause acute kidney injury. She said she was previously taking some NSAIDs a long time ago, but her doctor had already taken her off those. But that's a common finding in my clinic. Patients taking diclofenac, Mobic, and other types of NSAIDs that are not your routine NSAIDs, like Motrin or Aleve, but they're some of your uncommon ones. So always inquire about medications. And the final question is, what do we do about the metformin? This patient has metformin-induced lactic acidosis. Her serum bicarbonate was 13. You always stop metformin if your GFR is less than 30. No patients with a GFR less than 30 should be on metformin at all, under any circumstances. Why? Lactic acidosis is fatal. It can take your patients out. It doesn't mess up their kidneys, it messes up the patient. There's a huge misconception about metformin in kidneys. Metformin doesn't cause kidney failure in of itself. It causes acidosis. Acidosis is what causes all the problems that we see in patients on metformin. That's why we stopped the metformin. So this patient's metformin should have been stopped prior to coming to see me, but that's okay. This is what I do. This is my job. That's why we get paid the big bucks, to know who should stop metformin on. So we stopped the metformin. So the next question is, what do we do about her diabetes now that we stopped the metformin? That's another good question I would love to throw at you primary care providers. We stopped the metformin. Now her sugars are going to go out of the roof. What do we do? Patients like this, I always put them on another diabetic or hypoglycemic agent, such as glipizide, glyburide, Januvia, or some other agent, even insulin. I've started patients on insulin when I stopped metformin, because a lot of them didn't mind being on insulin. A lot of them had some insulin at home that they were not using. They said, I don't mind giving myself insulin shots at home. So in this patient, I started her on glipizide, 2.5 milligrams daily. It was the extended release version. And the reason I did start it on the lowest dose is because she's in renal failure. Patients in renal failure or an acute kidney injury situation have an extended half-life for a lot of drugs that they take in. So putting her on glipizide puts her at risk for hypoglycemia. These drugs usually have a 12 to 24 hour half-life, but if their GFR is compromised, like in this lady, her GFR was 14, the half-life of those medicines, glipizide, Januvia, is going to be a lot longer. I've seen patients who was on a glyburide type agent, the sulfonylurea, and they came in the hospital with hypoglycemia, and it took 72 hours. It took 3 days for it to get out of their system and for us to get their sugar back up to normal. We had to put that patient on a D5 infusion, and this is the typical thing that we see in the nephrology world. And we're called in because, it involves the kidneys. Usually the patients are in renal failure. They're having some type of issue that needs to be fixed from a renal perspective. But if you guys know to stop that metformin on the front end, and if they're hyperglycemic, put them on a low dose sulfonylurea, a low dose, diabetic pill in place of the metformin, you can kind of stop some of this stuff from occurring. This patient also was started on sodium bicarbonate. Usually I start 650 BID, TID, or 1300 milligrams twice a day or 3 times a day. to try to help bring their serum bicarbonate levels back up to normal. This was a great case. I think it had so many teaching points: metformin, risk factors, side effects, acute kidney injury, how you work it up, how you manage it, what do you do when you stop metformin in patients like this, how do you treat metformin-induced lactic acidosis. So I hope this was a really good case for you all. I hope there was some good learning points that you can take home with you, take to your clinic, and put into practice today. Go back and review this video again. You can also check us out on our free webinar below. Click the link. Or you can check us out at Nephrology Course Online. We've created an online course for primary providers like yourself to help you really bridge that gap from medical knowledge to clinical application. I hope I see you in the next video. Send me questions, send me likes, send me dislikes, subscribe. You know what to do. Thank you for tuning in. This is Dr. Hall. We'll see you in the next one. Bye.